So very good afternoon to one and all present here today for a webinar on role of clinical microbiology in patient care, which is predominantly much important subject today by considering the COVID condition, infections, and the flu arena right now. Today, I would like to welcome our eminent speaker, Dr. Suranjan Pal, Professor, Department of Microbiology, RGKR Medical College and Hospital, Kolkata, to take over the session. Thank you.
Very good afternoon, all the participants of this webinar. In the era of the modern medical science, the clinical microbiology is an emerging specialty. It mostly involved in the patient care and with a important role in clinical decision making. As we more progressing or advancing in the newer medical sciences, there is more role of individualized medicine. There comes the role of clinical microbiology, because we see the cases as unique one in every of the aspect. Clinical microbiology, to define, it is a specific combination of knowledge, attitude, and practice aimed at direct clinical involvement in infectious disease management using the core principle of medical microbiology and clinical medicine. So here what we learn in the microbiology, in the confines of the lab, we have to take part in the clinical decision making by encroaching, or what you can say, involving in the clinical aspect or treatment aspect. So the microbiology from earlier in the 1970s, when microbiology came from or separated from the pathology, in the early 60s, early 70s, 1968, first postgraduate course in medical microbiology started in Benares Hindu University. After that, AFMC started the journey. So mostly in the 80s, most of the medical colleges starting the MD microbiology course. Still, in today's NEET PG entrance, we get the medical microbiology seat, not yet the clinical microbiology. Now, today, before going into the proper discussion, we discuss some case. First, a case of 49-year-old post-COVID non-diabetic patient who developed rapid onset of swelling of face and pain on right side of the head. And was admitted to our COVID ward, and the samples were collected by emergency functional endoscopic sinus surgery by our otorhinolaryngology department. They sent us the tissue sample, but we got the nasal mass for both sent for biopsy as well as fungal diagnosis. It came out to be a rhinocerebral mucormycosis, which is a life-threatening condition in most of the immunocompromised cases. We grow the culture within 3 days, and immediately from the tissue we stained with the Gomoris methenamine silver staining, which showed the mostly a broad accepted hyphae, clinching the diagnosis of mucormycosis, and immediately liposomal amphotericin B started and the patient survived. Next case was a refractory non-healing ulcer with multiple discharging sinus of a 66-year-old male patient who was suffering this case for last 12 years. He had previously tried different type of indigenous medicine and also different antimicrobials, but leading to giving a deep scar on his soul. This lesion recurred again after 7 years. And after visiting several of the institutes or premier institutes of our country, came out to be, he visited our institute, and it came out to be a eumycetoma. This case, eumycetoma caused by Madurella mycetomatis, which was resistant to most of the antifungals. It was successfully treated with voriconazole. The patient was in the picture, he was getting the picture where the lesions has completely healed. So from these two cases, what we found that role of clinical microbiology lies in the identification of the pathogenic organism and the identifying in the patient's infection. In both of the cases, One got the life-saving treatment, another got the limb-saving treatment. And also another role of clinical microbiology in global disease outbreak detection, like that in the present era of COVID pandemic. Next is what is in the institutional based practice, the infection control practice and infection prevention practices. So these three role of clinical microbiology getting important day by day, and it has undergone changes with introduction of more of the molecular biology principle and bioinformatics, which leads to, because the clinical microbiology generates a huge number of data, and with the help of this bioinformatics and introduction of rapid molecular biology principles, we can coordinate themselves and also get a huge database which helps in treatment and getting prevention control strategy, as well as the different newer technology for diagnosis as well as treatment plan and prevention, like vaccination. Now, what a regular clinical microbiology lab does in our setting, it gets to sample collection. These samples are getting transported to the lab, and these things are in the pre-analytical phase of a diagnostic cycle. It involves mostly from the clinician's end. And next is the analytical stage where testing proper is done. It is done in the labs. And next is the post-analytical stage where reporting, analysis, and interpretation done. It is mostly done by the clinical microbiologist. Here, there are most of the error which is not controllable from the lab part, but is this pre-analytical stage. Most of the reporting depends also on this sample collection and transport. Now, what a traditional microbiology lab does, first, as the sample received, generates a unique number and gets to the direct examination of the specimen from microscopy. Next, culture and serology. Most of the lab does these three things in traditional microbiology lab. But with the advancement and newer technology development, what we are commonly getting, what we are doing, the culture-based automated rapid identification system, one by using the different biosensor technologies as well as some radioactive things. But here we can just reduce the number of time, reduce the time of the reporting, but still it is a phenotypic or culture-based identification system where we are using the different sensor principle. And next is this cartridge-based nucleic acid amplification test and chip-based nucleic acid amplification test and the real-time PCR machine. Most of the labs during these last 3 years have been introduced to these three kinds of machine because they are involved in the diagnosis of tuberculosis, mostly the molecular diagnosis of tuberculosis and the COVID diagnosis. Next, what are coming up on is the proteomic based analysis, like that of a matrix assisted laser desorption and ionization and time of flight mass spectroscopy, where if the proteins are generating different waves, and we thus from our huge database we analyze them, and with the help of bioinformatics we get the result within minutes. Next is the next generation sequencing machine, which is what we are getting different variants of COVID. But you can say that this sequencing turn identification of different strains. Next are the microarray, which is mostly commercialized by different companies like film array, etc., where a rapid diagnosis can be obtained by different clinical samples. This MALDI and NGS are getting from the clinical samples also. Previously, MALDI was standardized using the cultures. But most of the lab or diagnostic lab of a clinical microbiology domain do not have access to these things. Now, what is the diagnostic cycle of clinical microbiology with the physician? Because the clinical microbiology becomes clinical microbiology when microbiologists get involved in clinical decision making along with the attendant physician. So first, patients, what we get the indication of the diagnosis, and it is from the clinician's end where the samples are selected and samples are collected mostly, and they're sending the sample to the lab. After the specimen transport, this is the microbiologist side where primary workout, further identification using culture, identification using the traditional as well as the newer techniques, including the molecular diagnostic techniques, and reports are generated and reports are sent to the patient, that is the and also the customer, or here in case the clinicians also. So there is a constant flow of information from starting from the indication, then taking of the specimen with to the primary workout and the final report. Everything is the constant information flow should be maintained between an attending physician and microbiologist. Where it lacks, we just give the outside circle, that is the written report only can reach to the patient or the clinician. In the meantime, we lost a huge number of information, and that is the very golden information actually, because time is very much important in managing a infectious disease where we can lose or get a life. If we lose the golden time between the primary workout to the to this final report, because often there is lack of standardization and customized reporting is demand of the patient as well as the clinician. So we go on identifying further. During this time, the huge number of information is missing. Often the report reaches the patient, either patient has got has gone different outcome or not the expected outcome, like cure or anything, installation of the correct antimicrobial therapy. So crosstalk between attendant physician and microbiologist must remain at every time. What we can do, the qualified technologist or technician would do the day-to-day identification and analysis, that is the analytical part, and clinical microbiologists get involved once the primary result or final results are available for clinical action. That is why clinical microbiologists have a directorial role in a clinical microbiology lab, and the communicator as well as the suggester role of the management of infectious diseases. Now, domain of clinical microbiology in patient care, number one is the positive blood culture management, because blood culture is usually done in case of suspected sepsis cases, which is often the patient are in the intensive care unit and their patients are serious patient. So positive blood culture management is a integral and very important part of clinical microbiology practice. Next is a consultation of a range of infectious disease issue. The consultation with the physician. What to expect from a clinical sample. We must also communicate to the attending clinician why you are asking for this report, why these samples are taken. We can always suggest what other samples can be taken for the diagnosis, what he or she wants. And next also, what are the probable outcome of this disease. We also can consult with the infectious disease clinician as well as the choice of anti-infective therapy. Next is the policy making part, the hospital infection prevention and control, where the microbiologist must take a lead role, the clinical microbiologist, because he only can have all of the infectious data in the hospital, because most of the patients are sending the sample and we are generating a data and keeping also the data pool, and thus we can get or presumptive idea of what type of infection to expect from what different wards from a hospital, or what are the organisms to expect from a different wards of a hospital. So narrowing down to what is the commonest organism or commonest choice of antimicrobial therapy we can offer to the clinician, and thus a policy of antimicrobial can be formed, keeping microbiologists in the central part. But this hospital infection prevention and control must have a strong backing of the administration of the institute. Next is the leadership in diagnostic strategies and therapy, like to get the minimal inhibitory concentration of in antimicrobial susceptibility testing from different clinical samples organism, thus getting what are the different choice of drugs could be obtained, and getting to the therapeutic index part, which is the best of the lot to give to the patient. Next is the education and research, which is a continuing part of this diagnostic cycle, as well as because data is generated huge number, and also this clinical microbiologists often are educating the clinician as well as the students of clinic medicines as well as the postgraduate students, and research with the basic clinical research as well as the clinical research. Next is the business planning, which is an interesting part, because as newer technologies are coming into the clinical microbiology and helping decision making, clinical decision making, we can get a huge number of data also from the bioinformatics. Thus, we can get a like whole genome sequencing data, give rise to the what are the different organisms, thus what are the tests can be offered, and different technologies using the other sectors. We can do business planning also for setting up a different lab. Management of positive blood cultures is medical emergency. It shortens the turnaround time, it early result communication and early intervention, because the turnaround time is the very much important indicator of the diagnostic efficacy of a lab, because the time is important for life saving as well as different limb saving. I have also already shown. Next is the early result communication. Primary result, I stressing upon that thing repeatedly, that primary reporting is of utmost importance in clinical setting. Thus, the early intervention can be obtained. Microscopy from a positive blood culture broth from the like that of from automated system, we can directly stain from that broth and get what are the organism we are getting from that positive signaling broth. In case of the automated detection system, we must communicate it to the clinician, because gram stain promotes the choice of anti-infective therapy. Thus, as from the policy of an institute, we can give it to the patient. Next is the direct susceptibility test result. UCAST also recommends this direct susceptibility test from the positive blood culture broth from the automated system, and it can give rise to preliminary identification of the pathogen. Thus, this reduces the reporting time at least by 24 to 36 hours. Next is clinical microbiology in the intensive care unit. Intensive care unit patients are very sick. So ward rounds in an ICU is an essential part of a clinical microbiologist. If we are not getting going to the ward, we usually do not know what are the patients we are getting, what are the samples could be obtained, because often these ICU patients have different devices like central lines, the endotracheal tubes, the catheters, and often they are getting colonized with different commensal flora. So choice of specimen from the device as well as the blood culture specimen is very much important for life-threatening infection in case of ICU. And most of the hospitals are also getting the more samples from the ICU, as these are critical samples, and a single patient we are getting more than 3 to 4 samples per patient. And also as they receive more antibiotics, so they are to generate more of the multiple drug resistance organism. So antimicrobial resistance is usually higher in case of ICU. So that is why the role of a clinical microbiologist comes when these MDR organisms are getting from the ICU, and we are giving the choice of antimicrobials. and also to provide a infection control guideline to this ICU to prevent the spread of infection or acquiring the hospital acquired infection in the ICU patients or different wards. And another is the antimicrobial stewardship. Antimicrobial stewardship is a coherent policy of an hospital or institute to get to the proper anti-infective therapy. So antimicrobial stewardship is very much important, and the clinical microbiologist is the pivotal in case of antimicrobial stewardship. Next is the clinical microbiologist in a case of multidisciplinary meetings. Because as we are constantly communicating with the clinician, we must facilitate communication between clinician and microbiologist by arranging a weekly meeting with the clinician as well as case presentation by the postgraduate students of different clinical discipline, and thus by phone we can give a constant feedback, as well as by WhatsApp group or any kind of telephonic conversation between the clinical department and microbiologist. We also can go for some clinical meetings weekly, because there should be a structured list of patients and the patient's antimicrobial choice, because there is a role of periodical evaluation of the antimicrobial from time to time. Next is the hospital infection control. What is the infection control is everyone's responsibility, starting from the doctor to the microbiologist to the administrator to the group D staff to the other nurses to the technologist, everyone's responsibility, because we have to practice good infection control. Because the most of nowadays it is coming up in the health insurance also, the in hospital acquired infection are often like that of carbapenem resistant enterobacteriaceae, vancomycin resistant enterococci. These are often included, these infections are often included in the health insurance policies also, because these hospital acquired infection claims are also there. So here the clinical microbiologist roles are supervisory, whether the ward attendant, nurses and doctors are following the infection control protocol which is prescribed by this antimicrobial stewardship committee and hospital infection control committee. And also microbiologists must take a leadership role in planning the infection control practices and to give a policy making role. Patients in well-being, institutional reputation is also at the stake, because most of the hospitals which are having a lower hospital acquired infection status also get through the different accreditation agencies like NABH, they are giving a stress on this number of hospital acquired infection incidences also. So in case of accreditation, it has a role. Now, this would inevitably mean that microbiologist must be the decision maker, while clinical communication of the nosocomial pathogen and implementation of the infection control precaution. Hospital policy making with regards to the infection control and surveillance. Surveillance means keeping a constant watch. Next is the biomedical waste management and sterilization disinfection. It is also in the scope of the different accreditation of the hospital as well as the laboratories. And outbreak management. Outbreak management is an additional or another role when the clinical microbiologist takes the center stage. With the medical microbiology, usually when they remains in the lab, you will not get the option of this outbreak management. Next is the anti-infective policy. India have an anti-infective policy since 2015 to 2016. The latest is available in the 2019, where the treatment guideline for antimicrobial use for common syndromes are there, but I doubt whether they are practiced regularly or not. It is used to combat the development of antimicrobial resistance, estimate the cost and safety implication, that is a clinical audit, which is also a role of clinical microbiologist, and including the administrator. The microbiologist is central to the policy development of these anti-infective agents. Next is the emergency out of hours responsibility. The microbiologist often decides in the metro cities and mostly in the larger cities where they enjoy their 9 to 5 duties, because most of the time they get what the lab reports they get signed and sent to the wards. Emergency out of hours responsibility comes when the diagnostic service, like what we mostly offer, is the reporting of CSF smear after hours, of even when they send us CSF smear, we report whether there is any bacteria present or not at present. That is only the diagnostic service, and also the malaria parasites in the emergency department. What other the clinical microbiologist can offer being on call is the technical. When there is diagnostic difficulty, what they can suggest, that what are the tests the patients, what are the tests can the clinician offer. Next is the clinical, that means when what are the drugs they can give to the patient. An infection control component, like if there is any report of any case of the isolation precaution or any droplet prevention role, the residents or the attending clinical microbiologists have a role in the, they can go to the emergency out of hours, or they can consult over phone. Next is the clinical microbiology and public health. Clinical microbiology and public health, it is often a neglected topic, but it is coming up in case of this pandemic situation, where the ICMR, that is the Indian Council of Medical Research, has taken proactive role of setting up of nationwide laboratory network by means of viral research and diagnostic lab. Over by March 2021, there is about 126 laboratories in VRDL that is present in our country. There is target of 160 laboratories to be set up. Next is that there is presence of a older kind of public health reporting system, that is integrated disease surveillance project, through which we send different vector-borne diseases data, different foodborne outbreak data, or outbreak data mostly managed to this IDSP. The national health programs like that of National Viral Hepatitis Control Program, the NTP, that's National Tuberculosis Elimination Program, and also the HIV program, that is the NACP, National AIDS Control Program, all are there in the place. And laboratory, that is the clinical microbiologists, are very much important in reporting to that through the central agency of the network and spreading and dissemination of the reports to the different primary healthcare physicians also. Next is the defining features of clinical microbiology. Now, what a clinical microbiologist will stand out against the traditional microbiologist? The clinical microbiology must recognize and assess the clinical problem. That means we have to see the patient, we have to go to the ward, and also provide various important input to the clinician regarding the sample, proper sample collection, and what other different tests we can offer, what are the drug or therapy which are available regarding the treatment, anti-infective treatment option. Because to remember that we have this, we have to give the antimicrobial suggestion. Otherwise, there is limited role in case of the clinical microbiology. Distinguishing the pathogen from colonizer, commensal, and contaminants. So if we are not having any idea of what are the samples we should take from a patient, or what are the organisms to expect from different sites of clinical sites, we are not able to distinguish pathogen from. This is the basis of clinical microbiology. Next is the interpretative comments. If we do not have any interpretative comments in a report, that is like a piece of paper which can easily be generated by any of the machine. So the judgment and interpretation of the microbiologist is very much important, because the machine generated reports are coming up, and artificial intelligence are also fast encroaching into the different diagnostic as well as clinical decision making. So interpretation is very much important. Next is the COVID. To say that what COVID or coronavirus has given an identification of this clinical microbiology discipline. As often in our older years, what you are studying microbiology? Are you not a doctor? Or you are, I thought you have been training in the medicine. So COVID, after COVID, most of the clinical department started to communicate with us. The first and second wave of the COVID has exposed that is the loopholes and there are very much loophole and deficiency in our healthcare infrastructure. Funding and different through different agency like ICMR, DHR, and also our government funding, and also from UNICEF, we get development of we got to develop our labs. We are DL, COVID, RT-PCR lab, sequencing lab. There are also development of the biorepositories for COVID. There are about 17 to 18 biorepository nationwide, where we are storing the different COVID samples and as well as the COVID strain to generate further diagnostic strategies as well as the vaccinations. To till date, by about 71 crore test has been done, which is a huge volume and a commendable one. So COVID has defined the role or highlighted the role of clinical microbiologist, because most of the cases COVID reporting was very much prompt. Next is the total lab automation and clinical microbiology. Now, clinical microbiology, as they're getting to the personalized medicine as a influx of the newer technology, the total lab automation resulted in improved efficiency of the sample processing and sample outcome, because there is less chance of human error, obviously. Then enhanced recovery, the total lab automation also generate the more fastidious organism, that is often it is a algorithm based, so standard procedure and automated culture interpretation by through machine learning, artificial intelligence, there is also we are getting to that, and also thus which boils down to reduced time to report. And thus this, if we interface this automated system, total lab automation system, with the laboratory information system, we are getting very swift spreading very or disseminating very information very swiftly to the clinician or to the patient, thus making an early therapeutic decision. So total automation in the laboratory is the future, and we have to cope up with this because it is a data intensive procedure. So more data as we generate, this total lab automation system will get more robust. Now, what is the these two total lab automation which are not still in our country, the Copan WASP lab and BD case study total lab automation, which reduces the output by a day or at least, where starting from the inoculation to the plate reading, and in plate reading it is done, but the interpretation, the clinical microbiologists have a decision making role. So a single technologist and a clinical microbiologist, even if on a telephone or other connectivity measure, we can give result of a voluminous amount of sample. So this total lab automation. Next is the artificial intelligence and machine learning. It is still in the nascent phase because there is no a scope of development, because as we are getting more open access data of microbiota through whole genome sequencing as well as the biorepository data, this machine learning will get further developed, and a long-term cost benefit will sustain. So sustainability is an issue, and also this standardization of this machine learning. Despite systemic reporting, but still machine learning is under development. Now, what are the scopes? The expanding need for automation. it is an we have to embrace the technology. No arguing in that, because we have to advance through our technology and also expect that automated system had to be utilized. Next, also the automated interpretation, which will come up eventually. The role of clinical microbiologists will get further further shortened. Then increasing voluminous data and their management and governance of data privacy. This lab will generate a huge amount of data, but the data management and privacy will be an important issue, because we cannot, we often will not be able to share some of the private, because we can share anonymous data, but still the data privacy will be an issue. And introduction of new high throughput data intense technologies like multi sequencing and also other this bioinformatics system will come up eventually. Biodepositories will also provide the important data for further development of diagnostic strategies and local entrepreneurship. Ultimately, the new development of newer technology will be the future of clinical microbiology, where if we are not getting involved in the clinical decision making, the role of bench microbiologist will be diminishing day by day. So we have to include ourselves or thirst upon the clinical decision making. So we have to come out from the confines of the lab. Next, what will be the future of a microbiology lab? There will be some separate satellite lab where they will do the rapid microbiological test and we send the sample through enhanced transport system like pneumatic tube system, transport system. Then they will get to a central lab where there is microbiology, where the infectious disease serology and rapid test will be done. Then it will be connected total lab automation platform where the culture and further test will be done, and the connected molecular biology where from the total lab automation, if further identification is required, this molecular biologist will identify. If there is a chance of referral, that will refer to the national referral lab or other referral lab, which will integrate the data of WGS as well as the next generation sequencing with the biochemistry, immunology, etc. And further, this data will generate, give the rise to the statistics and epidemiology through different software, that is HUNET and ECDC, etc. will be sending the data. And further, this biomedical hospital management will keep up this data and bioinformatics platform will store. And further, from this data, we propose what will be the anti-infective treatment, infection control strategy, what further diagnostic strategy or newer development can be done, which will be in the part of the translational medical unit involving the biochemistry, hematology, immunology, etc., which will require the private funding. So the future will be mostly the technological advancement dependent, and the microbiologists have to go to the lab, from the lab to the ward, and especially critical care unit. So we have to be prepared that we may have to do more work, more out of hours reporting, and more ward round, more communication with the clinician, and more also information to the regarding the antimicrobial therapy. What currently is status of training and practice in India, that infection control, these hands-on mostly are what the PGTs or the postgraduate trainees are getting extensive technical work. The first years or the residents are most often doing on the bench work and involved in the result analysis, followed by some amount of interpretation with the help of the consultants. Next, a significant assignment of the teaching. Different kinds of students on different course related, this medicine, MBBS courses, BDS courses, allied medical courses, nursing courses, etc. And in some part of their dissertation, the research and analyzing the data. So they are mostly involved in the lab work. Rarely they go to the ward. When there is an interesting case, the resident go to the ward to collect data. That is not usually a part of a routine procedure in most of the government medical college level labs. There is introduction of competency-based medical education, including the 8Com from undergrads that help the MBBS student to not only get the bookish knowledge of medical microbiology, but to have identified the case-based scenario and mostly the infective syndrome-based diagnostic approach, which is the ideal for infectious disease management. Still, there is not much effort to interface the laboratory result with the clinical management, but they are starting this competency-based medical education program has been started from the last year. So we hope there will be getting more clinically oriented students and microbiologically oriented interns or residents in the near future. Around 500 seats is allotted for per year for MD or DNB microbiology. So if you are going to generate more of these lab microbiologists, are we missing out on opportunity? When the microbiologists are confined to the lab only, when they're not getting enough clinical data, not visiting the wards frequently, when there is often the lack of clinical information from the clinician part, like not a proper filling up of the specimen requisition form. Why not this time from the clinical microbiologist, we get proactive, we go to the ward, collect the clinical data, not dependent on this incomplete requisition form. So ideally there should be some clinical posting for these residents, so to get an taste of this clinical microbiology. Now, what lies in the future of the healthcare? There will be virtual healthcare mostly, because in the era of the communication, that is more of this WhatsApp, email, or other telephones, video calls, virtual meetings. Even this is a virtual meeting. So the consultation from a single case from like that of the other part of the world easily can be consulted with the expert of the in this field from other. So virtual healthcare is a future. Then acute care will need more specialized services, more individualized medicine. So more clinical oriented microbiologists to what we will get from this different clinical sample to get an ideal sample to generate more yield from the samples. Long-term care will need more regional cooperation like that of from the collaborating research lab as well as the central lab, different regional labs. There will be more home care support. So consequently, the microbiologist, mostly the testing, microbiological testing will be point of care test. Well, when there the clinician can do the test, even the patient can do the test like that of a COVID self-testing. And newer business model will thus come up like this, including into the point of care test. So more of the newer technology, more of rapid diagnostic, more of the funding from the other business houses, not from the traditional medical businesses like from the Walmart or the Amazon, but they're into the medical or the clinical microbiology business, where an estimated report of 6.7% increase in the clinical microbiology outcome. This is a huge market. As well as Amazon started this self-testing in America, and they're also getting this accreditation from College of American Pathologists. So there will be in future this business, a huge business will come into the diagnostics, and they will fund all of the labs. So there will be most of the point of care testing, and most of the lab will turn into the satellite lab. So if we are not this time proactive, we are not going to the wards, we must we may remain we may get extinct in the near future. So what are the detriments? What we can rectify from our side? We have to develop good communication. The poor communication is the major detriment between clinician and lab. Recurrence of serious problem with the timely specimen transport. So often there is a comparison of data between the delivery personnel transport and the pneumatic transport system. There is a huge increase in the yield in case of pneumatic transport system, but still it is not in practice in most of the lab. Time consuming customized reporting and standardization often precludes early installation of the appropriate anti-infective management. Impaired gram stain analysis. we must think that gram stain is a rapid test and it is of an utmost clinical importance. So primary smear reporting is very much important, and it is a there are huge scope of improvement from clinical microbiology lab. And compromised infection control surveillance. If you are not taking an proactive role, there will be chance more of the hospital acquired infection and more development of antimicrobial resistance. So infection control practice is a major role of clinical microbiologists. So we have to do more work, identify more and more organisms, report complex and changing drug-related info, including the therapeutic index and MIC-based reporting. We have to embrace the automated procedure because it will be the future of clinical microbiology, and integrate traditional lab data with the molecular finding. We must always try to develop a biorepository and fully characterize the lab results, which will be of huge or immense help in future planning of the infection control management and newer diagnostics development. And participate in the public health reporting for, like in this case of what we can easily see in case of the COVID pandemic. Public health reporting is very much important for outbreak detection. Next, I would like to acknowledge my sincere thanks to the Department of Microbiology at Jikor Medical College, which is my alma mater also, and also my students and my teachers. Thank you.
Thank you, Doctor. Doctor, can we take up a few questions?
Yes, we can.
Yeah. The first question is, do you feel that clinicians need to write the history of present illness and drug history on the sample requisition form?
It is very much important, because we cannot rely on the clinical samples only. We have to get to the clinical history. That is why I am stressing upon, if we are often getting this kind of incomplete requisition where there is no clinical history, no antimicrobial history. So we are often not getting whether this patient will be the appropriate sample or not. In this case, what we can do, we can solve this problem easily, not depending upon the clinician, giving a regular clinical round. We can choose the sample accordingly, consulting with the clinician depending upon the indication of the patient. Yes, surely there is need for complete filling up of these requisition forms.
Thank you, Doctor. Next question. Can you please summarize the duty and responsibility of a medical microbiologist?
The medical microbiologist duty, first one is the reporting with consultation of a physician, the infectious disease agent. Number 2 is formation of an antimicrobial policy of an institute. Number 3 is giving a proper antimicrobial policy, including the antimicrobial stewardship, taking a leadership role in the infection control practices. Next, ensuring the quality of the report by participating in different kind of quality assurance program as well as accreditation programs, and also keeping vigil of any unnatural occurrence of any infection in your hospital or community, and do a outbreak reporting if outbreak generates. But must we is that to report starting from the primary result, and a constant communication between the lab and as well as the clinician.
Thank you, Doctor. Next question is regarding antibiotic stewardship. Who other are important stakeholders and why it is not implemented in majority of hospitals? Does it exist in your hospital?
Antimicrobial stewardship in our institute is still in the nascent stage. We have an infection control committee which proposed the antimicrobial stewardship. the role of stakeholder is very much important from the starting from the clinical departments, the pharmacy, the infection, the administration. We need a strong administration backing for implementing the antimicrobial policy and a broader aspect in antimicrobial stewardship. Clinical microbiologists, what he can do is mostly take a lead part and act as maintain a constant communication between these all three domains: clinician, pharmacist, as well as the director at administration, and also include a strong infection control team, which comprising the clinical microbiologist, infection control nurse, and others also.
Thank you, doctor. Next question. Don't you think better than microbiologist, a clinical pharmacologist can guide in selection of right drug?
Clinical microbiologists definitely have more knowledge in drugs, but the infection control practice is mostly involves the isolation as well as identification and reporting of the infectious agent. So the pharmacy role is important always, but the infectious agents and how it will behave, I think it is more a purview of a clinical microbiologist. And thus, with the help of or consultation of the clinical pharmacology, it can be more strongly assessed. And if as our country is now developing the infectious disease program, teaching and training program, we'll be getting more of the infectious disease specialists in near future, who will be the leader in case of this clinical microbiology infection control also. So clinical microbiology and as you asked, clinical pharmacology can always give inputs, and being a consultant, he or she definitely have the more knowledge in drugs, but as infectious agents, I think clinical microbiologists have an important role.
Thank you, doctor. Next question is, what do microbiologists say about COVID-19? A lot of people tend to take a number of antibiotics.
COVID is coronavirus disease, so it is a viral disease. Antibiotics are used to treat bacterial infection. So by definition, COVID antibiotics will not have any role in COVID, but there are some opportunistic infection, COVID associated pneumonia. In case of COVID associated bacterial pneumonia, there is role of antibiotics, but as such COVID antibacterial will not have any role in the viral infections.
Thank you, doctor. Next question is, what are the challenges of clinical microbiology department in the context of COVID-19?
Clinical microbiology is often a smaller department in a case of a hospital, mostly as they have no clinical microbiology setup, they are medical microbiology. So in case of the question is the COVID-19 and clinical microbiology, am I right?
Challenges faced by clinical microbiology department in the context of COVID-19.
Challenges are the most of the labs were not upgraded at the time for molecular diagnosis. So mostly the COVID, as it is a viral disease, there is less, the ultimate diagnosis will come to the molecular diagnosis, not like the of serological or phenotypic based diagnosis. So well equipped molecular biology lab in medical microbiology setting was lacking. So we have faced a problem at that time, but with the government funding and funding of different agencies in that epidemic and pandemic situation, the microbiology labs developed further, and there are around more than 1,000 labs we are doing Around nearly 2000 labs are doing the molecular diagnosis for COVID at present. I told you that earlier that there are 126 at the time of 31st March 2021. They were diagnosing this VRDL, or viral research diagnosis lab. There has been huge funding and development in the last 2 years. So we have faced infrastructure problem. We faced manpower shortage. We are stressed with the work hours. So also, but with the support and backing of administration, that is government, I thought we tried our best to combat this COVID challenge.
Thank you, Doctor. Doctor, I think we have taken up all the questions right now. Should we wait for a few more questions, or can we end the session?
I think it is 3:55. We can take one or two questions.
Okay. Doctor, I think we have taken up all the questions, so we can officially, close the session for the day. Is it okay?
Yes, thank you.
Yes. So thank you everyone for joining us today for the informative webinar on clinical microbiology in patient care in the context of COVID-19. Once again, thank you to our beloved speaker, Dr. Suranjan Pad, for spending, in a Friday afternoon along with us in explaining the importance and the strategies that we need to follow, and what are the opportunities available in the country right now for the medical microbiologist, and the future as looking AI, artificial intelligence, and lot of developments that we are going to expect. Thank you, Doctor. Yeah, thank you, everyone.